The Canadian Association of Clinical Thermography is dedicated to making thermography more accessible and available to those who seek it. Become a supporting member today and help us transform the way medical thermography is understood in our world by practitioners and the general public. Visit us today and join us.
All right, everybody, welcome. Again, thank you for being here. And we are very excited to learn about complex regional pain syndrome and thermography. And with that, I'm going to introduce our very good friend and colleague, Dr. Philip Getson. Dr. Philip Getson is an internationally recognized expert in the diagnosis and treatment of complex regional pain syndrome and has lectured extensively on the subject at national conferences such as Pain Week and the American Association of Pain Management, as well as internationally. He is a former member of the Scientific Advisory Committee of the Reflex Sympathetic Dystrophy Association of America and one of their designated speakers. He was the presenter at the RSD Association's online CME accredited conference for doctors to enable their understanding of the disease. To date, he has evaluated over 2,000 patients with CRPS, and his YouTube presentations have been viewed by more than 250,000 individuals. He was an assistant professor of medicine in neurology at Drexel University College of Medicine in Philadelphia until its closing, and a member of the medical staff at Virtua, Thomas Jefferson University, and Cooper Hospitals. His work at Drexel, in collaboration with Dr. Robert Schwartzman, included formulating the initial protocols for in- and outpatient ketamine infusion therapy, and was one of the first physicians of the country to utilize this treatment for CRPS. He's a board-certified thermologist and has reviewed more than 50,000 thermographic studies of the breast, thyroid, dental, and neuromuscular systems since 1982. He has been certified by 4 thermographic boards, has lectured nationally and internationally regarding thermographic testing, and has authored several papers on the subject. He served as vice president of the American Academy of Thermology, during which time he was the chairman of the committee responsible for formulating the first ever protocols for breast and neuromuscular thermography that has since been accepted by the national and international thermographic communities. So without further ado, I'm going to hand it over to you, Dr. Getson. And again, thank you so much for being here with us today.
Well, I thank you for the opportunity, because it's always been a passion of mine to educate. And the more people that we educate, the more people that understand, and the more people that understand, the more people we get accurate diagnosis. And I don't wind up seeing people who have been to 5 or 6 or 7 doctors with misdiagnosis, and then we're trying to undo the mess that was made. We're getting it from the front end, and it's always easier to treat people once you get them at the beginning of the problem and not in the middle or somewhere down the line. So my goal here today is to sort of give you a beginning inkling into what CRPS is and what we can do thermographically in terms of diagnosis to facilitate a more rapid intervention from a treatment point of view. I'm not going to give you a comprehensive understanding of CRPS. It would take far longer than we are planning on using today, but the information is out there, and at least maybe we'll whet some appetites and pique some interest in this for people to move forward and get a little bit more information. So complex regional pain syndrome is primarily a neuropathic pain disorder, and it is characterized, as you see, by the 5 items that are there. Now, for me, I put them in an order that makes sense here. The underlying part that talks about disproportionate to the inciting event really will be understood a little bit better when we talk about the Budapest criteria. Please understand that you do not have to have all 5 of these, although most people do. And most people come in complaining about pain, and the comment disproportionate to the inciting event really means that somebody sprains an ankle and 6 months later that ankle still hurts or hurts more. This has been a hallmark of diagnosis as we move forward. Almost always, the pain is burning. I mean, that's kind of my buzzword. When I say, what's the nature of the pain? People misunderstand. They say it's bad or it's real bad or it's 10 on a scale of 10. But I want to know what the pain feels like. And I don't lead people. I don't say, is it sharp or dull or this, that, the next thing. I want them to use the word. And I almost always hear that word, burning. And so the RSD has described the signs and symptoms that are here. And I don't need to read them. Again, you do not need to have all of these. These are things that people discuss, people mention. You see, I've underlined the word burning. The traumatic event can be sprain, fracture, minor surgery. Uh, what's the most minor that I heard? I had a woman who was a seamstress. She stuck her finger with a bobbin needle. The needle punctured it, as we've done so many times in our lives, this little pinprick, so to speak. And within 6 months, she was so incapacitated by CRPS that she couldn't get out of a wheelchair. So it does not have to be a major inciting event. It can be something as innocuous as I just described. People talk about allodynia, pain response from stimuli that do not evoke pain. You can take a cotton ball and run it down the arm of a CRPS patient who is afflicted in that limb, and they think you got a blowtorch. You get abnormal swelling, you get abnormal skin color changes, temperature changes, and the temperature changes, as I will discuss later, are the main reason that thermography is so important in this disease. Okay, so I want to show you something that I found, and I think it's really important, and I call your attention to the underlying words: migrate, stabbing, shooting, burning, again, that I've repeated on so many occasions, affected by cold weather, affected by humidity, includes non-restorative sleep, physical incapacitation, exacerbated by inactivity, stress, and anxiety. And here's some more. The pain can migrate from one part of the body to the other. It can be described as stabbing or shooting. Again, you see the same thing: cold weather, anxiety, stress. And so this is a terrific explanation of what CRPS is. There's only one problem. That came from the National Fibromyalgia website. It is my belief, and it's also the belief of two groups of doctors who wrote this, that fibromyalgia, and I run into trouble every time I say this, fibromyalgia is not a separate entity from CRPS. It is actually a subsect of CRPS. And there's always a rheumatologist in the room listening and saying, well, wait a minute, what about this? And we agree to disagree. But I cannot tell you the number of people that I have come in who tell me that at one point in their life they were described as having fibromyalgia, and in point of fact something happened and it got better, and all of a sudden they have CRPS, and in point of fact, in my mind, they always had CRPS. It was just misdiagnosed erroneously as fibromyalgia. So if you go back and you look at those slides that I just put up there, and you take and match them up to the slides that explain what CRPS is according to the CRPS website, it's almost an overlay, one on top of another. So next time you're looking at someone and they tell you that they have fibro, or somebody that has been diagnosed that come to you for treatment of the fibro, at least consider the possibility that it is a subsect of a much larger entity. So the International Association for the Study of Pain in the 1990s came up with a series of criteria, mostly for physicians to be able to sell the diagnosis of CRPS to insurance companies. It wasn't so much for physicians as it was because there was so much confusion as to what CRPS was. So they met in Budapest, Hungary, and they put together the 4 criteria that you're about to see. And they said, if someone meets these 4 criteria, then they can be diagnosed with CRPS. Well, there's a bit of an issue with that, because what happens if they don't quite make it? Like you see in number 2 here, it says they have to have 3 of the 4 categories. Well, what if they have 2 of the 4 categories, but they meet all the other criteria? So it's a generalized guideline. It's not meant to be strict in any sense. It is constantly in flux, but it's the best we have right now. And if you're trying to get authorization from an insurer to understand that the individual that you're treating has CRPS, okay, this is what they use. So The first one, continuing pain disproportionate to the inciting event I mentioned. 2 and 3, as you're about to see, are symptoms and signs, but beneath that, sensory, vasomotor, sudomotor, and motor trophic are exactly the same. Symptom being that which a patient complains about, and sign being that which you as the clinician see. To me, the most important one of all of these is the last one that says there is no other diagnosis that better explains the signs and symptoms. And we all understand as clinicians or as patients or as caregivers in any fashion that we live in a rule out world. You know, if we know what it isn't, sometimes we come in the back door and we know what it is. And so you have to eliminate other causes for the patient's pain or symptomatology. Doing so, having done that, you can add in this number 4 that talks about no other diagnosis. Sometimes if somebody comes in and they meet 1, 2, and 3, then 4 becomes self-evident. So as you saw with the fibro explanation, these are just some of the things that exacerbate CRPS. And the 3 in red to me are the most important. It's not so much humidity, it's not so much cold, it's a change from of the barometric pressure from warm to cold, from cold to warm, infection. But stress is the first one on there for a reason. And understanding living in today's world, we all live in stress, but I'm talking about stress above and beyond that. You know, somebody who has a family member that passes away or loses a job or whatever it is, guaranteed this CRPS is going to accelerate. So here's the myth. There is no diagnostic test for CRPS. Everything that you see here, x-rays, CAT scans, bone scans, and I'll come back to that in a minute, discograms, myelograms, etc., become rule outs. Electrodiagnostic testing, EMGs, really are a test of motor function of the nerve more than sensory, and this is a sensory nerve disorder. So somatosensory evoked potential testing can give you an inkling into CRPS. Quantitative sensory testing, which is very hard to find someone that has it, can give you an inkling into that. Triple phase bone scans are an antiquated test because they're almost never positive. They're almost always non-specific. I don't do them because it gives the insurance company a chance to say that it's negative, therefore the patient doesn't have CRPS. So it leaves us with thermography. Those of you who are listening who are familiar with it, those of you who are thermographers understand what I'm doing when I say this. It is a non-radiologic, non-invasive test with no adverse effects or contraindications. It is FDA cleared in this country, and it really has the great benefit of being able to image the nervous system, especially in chronic pain conditions. The nervous system, the blood vessels either become cold or hot. We're measuring temperature, skin surface temperature with thermography. And as it says in the third line there, a hallmark of CRPS is excessive vasoconstriction of blood vessels that can cause cold hands and feet. Thermography provides images of the sympathetic nervous system. And given the fact that CRPS is a sympathetic dysfunction, it becomes a perfect tool. Let me say this, if you image a patient, it's my experience, in the first 6 months or so of a CRPS inciting incident, the affected limb is going to be the warm limb. Vasoconstriction kicks in about 6 months time, and it becomes the cold limb. So obviously you need to correlate the patient's symptomatology with the thermographic findings. About 20% of all patients that have abnormal thermograms with CRPS will show warm throughout. So it becomes diagnostic, not so much as warm and cold, but we're looking at the asymmetry. So I want to give you a few case histories. I'm going to give you one here, talk a little bit more about CRPS, and come back and give you a few more. So here's the history. This 40-year-old female was on the 3rd row of Lincoln Financial Field, which is the football field in Philadelphia. And there was a charity event, and what happened was that the kicker, the punter for the Eagles, kicked the ball up into the stands, and the crowd would throw the ball back, and he'd move along and kick it up into the stands and go around the entirety of the stadium. Well, he hit it up a little farther this one particular time, and the individual who caught the ball thought he was a professional quarterback and he was going to heave it all the way down onto the field, and he didn't quite make it. He made it as far as this particular woman who saw this ball hurtling at her face, point end face first, and she stuck her hand up to prevent the ball from hitting her face. In doing so, it hyperextended her wrist and she broke her hand. She did not break her wrist, she broke her hand. She went and had x-rays. She was put in a cast. The cast came off. The hand was discolored. The hand hurt more than when she broke it. She went to the doctor who couldn't understand what it was. And she came into the office with this type of thermographic image, the broken hand, the left hand being on the right side of your image. And so if you've never seen a thermogram before, okay, this is her right hand, this is her left hand, and there is over this side a temperature scale, which you can't see, but I will tell you that the highest temperature is the warmest temperature, and the coolest temperature at the bottom is the coldest temperature. And so when you compare areas, I mean, forgetting about the numbers that I'm going to show you in a minute, but clearly the right arm is warmer than the left. Yellow is higher than blue. Green is warmer than this purple color. And where there should be fingers down here, there really aren't, because the hand is so cold that the temperatures drop off. And down here, we're looking at average temperatures, and we're seeing numbers that say 2.2, 2.0, and 3.0. And the margin for abnormal actually falls at 1 degree centigrade. So this woman is 2 to 3 times beyond the accepted normal. This is not going to show up in any possible entity other than vascular disease and CRPS. There are no other explanations for this. And certainly if a person had vascular disease, it would be easy enough to determine, and it would be extremely unlikely for all of the blood vessels from the forearm down to be affected. And here's the picture of the lateral view. This is her left arm, and you can see that the problem originates in the lateral deltoid and it goes all the way down the arm. Well, if she broke her hand, why is it in the lateral deltoid? Why is the abnormality not just in the hand? Why is it all the way up into the arm? And the answer becomes simple. This is a person who has CRPS because when she hyperextended the hand, she damaged the nerves in the hand, or she damaged her brachial plexus in the movement of the arm with the impact of the ball ascending and going down to hit her face. So I'll come back and show you some more a little bit later, but I want to just talk to you real quick about some other things. There is a myth that says CRPS it invades the hands and the feet and no place else, and it's a myth. Because what you're about to see in the next 4 or 5 slides are symptoms of CRPS that have nothing to do with a hand or a foot. While the disease may have started in a hand or a foot, it internalizes itself, because please remember, the problem was never in the hand or foot. It's part of the central nervous system. It's affecting the brain. The brain controls the central nervous system. The central nervous system controls everything else. So when a patient comes in and has, for example, gastroparesis, it's because the message from the stomach to the brain and back is getting misread. So everything that you're about to see in the next few slides are all symptoms that people have from CRPS that doctors misunderstand, and they believe it to be something of a gastrointestinal nature, when in point of fact it's not. It's part of the CRPS. And in most cases, if you improve the neurologic condition, you improve the internal symptomatology. So here's a cardiac one. For those of you who may not know what they're seeing, this is the heart rate. Here, 1, 2, 3, 4. The heart rate is about 40 in this. Normal heart rate, of course, runs anywhere from about 60 to 80, depending upon male or female. This is a woman whose cardiogram showed her heart rate to be 40. She was tested extensively by cardiologists and has no heart disease. But the message to the heart from the brain is being misinterpreted. This lady wound up with a pacemaker with no heart disease. The problem was within the nervous system. Urinary problems, incontinence, inability, people get misdiagnosed with interstitial cystitis, which they don't have. Headaches, more frequently and not greater occipital neuralgia. They get misdiagnosed as migraines, but they're not. Visual problems, double vision, blurred vision, photophobia, extensive sensitivity to the eyes. ear, nose, and throat problems. Vibration is interesting. I have people come in and say they're riding in a car and somebody pulls up next to them and has the music cranked up and the bass cranked up, and it actually causes them to have pain when they're in another vehicle altogether. Intermittent hoarseness that comes and goes. Dental issues because the nerve root's compromised. I've had 20-year-olds who lose all their teeth because the nerve roots literally do not supply the necessary nutrition to the brain, and the teeth literally discolor and fall out of their mouth. Dermatology, you can see the picture down there, which comes from neurodermatitis. It's not a skin problem per se. It's a problem with the nervous system. Here's some more: shortness of breath, inability to take a deep breath, neurogenic edema. People come in with big swollen edematous legs who do not have heart disease and do not have vascular disease. So you can give them all the diuretic in the world and that edema is not going to go away. Muscle weakness and atrophy, endocrine problems, Gardner-Diamond syndrome, bruising in areas that were never traumatized, lethargy, fatigue, sleep disturbance. Down the bottom, short-term memory loss, which is very, very common. Treatment for CRPS, physical therapy, occupational therapy, different medications, pain management doctors who do injections and implant devices, ketamine infusions, which I'll talk to you about in a minute, and surgery. Now, surgery becomes necessary if there is an underlying surgically amenable problem. So if somebody has carpal tunnel syndrome and has symptomatic carpal tunnel syndrome, you will never get the CRPS under control until you fix the compression of the median nerve. Orthopedic surgeons generally will say, I don't want to operate on you because the CRPS can get worse, and they're right. But at the same time, the CRPS is never going to get better if you don't deal with the underlying problem. Okay, let me come back a second. Talking about ketamine would be an entirely separate lecture and take far too long for today's purposes. Ketamine is an NMDA inhibitor. There is theory that suggests that the NMDA center in the brain controls much of the symptomatology of the CRPS. So as a result of that, we're using a square peg in a square hole, so to speak. We're attacking the CRPS directly by dealing with ketamine infusion therapy. It is a very complex issue. You will see at the end of this that I have contact information. Anybody who wants to know a little bit more, I'll be happy to send you the information. Ketamine is, in my mind, the best treatment for refractory CRPS, refractory being a key word in that sentence. People who get ketamine infusion therapy, 80 to 85% of the time in my office, and I've been doing this longer than anybody in America, get better. How do you define better? They take less medicine, they have a better quality of life, or ideally, they take less medicine and they have a better quality of life. Okay? There's a right way and a wrong way. I'm not going to go into that now, but just understand that some people, we can do physical therapy, occupational therapy, do this. Medications frequently become opioid related. It creates a problem for opioid-induced hyperalgesia, but everybody's an individual. And when I see people, I've always got that ketamine in the back of my mind. If I can get them better, otherwise I will. If I can't, I don't. As far as surgery is concerned, we wrote a paper, again, available to anybody who wants to reach out to me, that talks about the use of ketamine in surgery. Just to give you a brief overview, before we wrote the paper, I had 20 patients in my portion of the study. I granted not a huge number. I had 20 patients, and we gave every one of them ketamine intraoperatively. And the surgery may have been from multiple dental extractions all the way down the body to podiatric surgery. And what happened was not one of them in that initial study extended their CRPS. So when my patients go to the operating room, I make sure that they have a note that says ketamine must be used intraoperatively, and I tell them if the doctor says they're not going to do it, get up and go home. Now, I've, since that study, have never had a patient extend their CRPS. Again, it's not 1,000 patients, but so far so good, and I keep my fingers crossed every time anybody needs much necessary surgery. Other than all those things, what about these things? Diet and lifestyle alteration, an extremely important thing. What you eat and what you do, extremely important. Down at the bottom, we did a study on a patient who had CRPS in her arms. My wife is a Reiki master. We brought her in and took thermographic images. She did a Reiki session for as long as that took. We did pre and post imaging. And at the end of 5 Reiki sessions, her pre and her post looked exactly the same. And when I looked at her pre from session 1 and her post from session 5, for at least that brief period of time, the physical manifestations were better and the thermographic manifestations were riveting. Okay. Hormonal neurotransmitter balancing, proper diet, proper exercise, trying to eliminate stress from your life to the best of your ability. The patient has to be a part of this process. If the patient's not a part of the process, they're in it to get their drugs or their treatment, you're not going to get them better. And you can pretty much tell as a treating clinician when that person's going to show up in your office. I give them this list of 7 foods to avoid. Most of them know about the first 6, gluten being the main one. Okay, nightshades surprises a lot of people, but nightshades accelerate pain in CRPS. There's a paper that's available on diseases caused by gluten, and one of them is fibromyalgia, among like 30 or 40 or 50 others. If I can get people to go gluten-free, it seems like it makes a big difference in their pain. MSG does the same thing. People will say they have to have their morning coffee. I tell them to drink their morning coffee. It's the people that have 6 or 7 cups a day that I'm trying to get to change. So let me talk a little bit about thermography and in a different fashion. And I'll do that through case histories. This is a 43-year-old female who was sitting on a plane in flip-flops, and there was a fragment of metal that was loose, and she cut her foot on a piece of metal and wire that was sticking up. And I didn't get to see her for 2.5 years later, because she had all the symptoms that you see in bold print. She had this feeling in her foot, but she had facial pain and ear pain and pain in the left sternocleidomastoid muscle of her neck and her elbow and her hand and her abdomen and etc. I mean, this lady was a walking pain clinic. And she'd been doctor to doctor to doctor and got to my office, and I put her in front of a thermographic camera. And I saw this in her leg, and I really wasn't surprised. You know, she had more heat in the right foot than the left, and that was okay because that was the area of trauma. And, you know, I really wasn't concerned with the heat. I was concerned with the cold. So, you know, maybe there was some scar tissue. Maybe I had a lot of explanations, but it didn't explain this lack of symmetry from her left foot to her left calf to her right calf that came down here, as you see, at 1.6 degrees. This doesn't make sense for somebody who cut her foot. It doesn't make sense that somebody who cut her foot would have all this kind of asymmetry in the inner portion of the foot. She didn't cut the inside of her ankle, and yet you have a difference here of 1.5 degrees. She had no trauma to the lateral portion of her leg, and yet you have this kind of asymmetry. And she sure didn't have any problem with her hand. Now, the asymmetry here is only 0.9 of a degree, half a degree. You can see it mostly in her finger. But look up here where there's this carve out of tissue because of the cold that you see off to the side. So why would somebody who had a problem with her foot have this kind of symptom in her hand? And the answer is because she didn't have a problem with her foot. She developed CRPS from an injury to the nerve in her foot. And all those symptoms that I explained a few moments ago in terms of her neck and her face and her breast and her abdomen was because the disease became a centralized disorder and gave her manifestations that we were able to image thermographically in other areas. What does this tell me? Well, one, it tells me that I've got a proper diagnosis, but two, it becomes a situation where I can sit down with the lady and show her these thermographic images and say, I can explain to you why you have problems with your hands. And that validation becomes so important, because not knowing and going into offices and having people say, well, I have no idea what's wrong with you, or, hey, you know, it's all in your head. You don't have a problem with your arm, or you don't have a problem with your neck, or you don't have a problem. Yeah, you do. Okay. So here's another one. I had a 58-year-old lady who fell down and put her arm out. Now, understand, when you fall down, the instinct is to put your arm out, and the instinct is to prevent you from face planting. And so what happens is that she goes to the hospital, they x-ray her radius and ulna, and she has a fracture, but they missed her brachial plexus injury because not only do you put your hand out when you fall down, but you lock your elbow. Because obviously, if you didn't do that, you would have a face plant. Well, when you lock your elbow, no matter how much you weigh, the trauma is direct traumas to your hand. But try doing this sometime. Try to put your hand straight, okay, and have somebody push against your hand and watch what happens to the upper part of your arm. It moves the upper part of your arm at the shoulder way back. And people don't realize, I think, I don't understand how, people don't realize that your hand and wrist are connected to your elbow and your shoulder. So they missed a brachial plexopathy, and she developed CRPS, which they were able to determine with a dystonic left upper extremity, and she had no other problem. So when she came in, we saw the dystonic left upper extremity. You see here that her fingers, with the exception of this little hint, here's her fingers. Her fingers belong here, but they're not there. You have all this heat in the right arm and all this cold in the left. I expected to see this, because this is what bothered her. What I didn't expect to see was this. Okay, why does she now have a cold right thigh and no symptoms? And so I have developed this theory, and I cannot refer you for any medical literature, but I've seen 2,000 CRPS patients, and I don't know how many CRPS thermograms, that you do a thermogram, and they never do an arm. So if I had simply done this lady's arm, I would have missed this. And I can tell you that when I see this kind of picture, at some point in time, that patient is going to come back and complain about pain in her right leg. Generally, it takes about 6 months, but at some point, that pain will manifest itself in the limb. And I am firmly of the belief that the thermogram, and it's a bad word, but I'm going to use it anyhow, has a predictive component to it. It's going to tell me where that CRPS is going to wind up next in a limb. Now, there's a paper in the Journal of Pain in 2001 written by my friend and colleague Bob Schwartzman that talks about migration of CRPS. CRPS moves from limb to limb. 90% of the time, I think it's 85% of the time, it moves contralaterally, ipsilaterally. It will move right arm to left arm, or will move right arm to right leg. And about 10% of the time, it will move right arm to left leg. So when I see this, and I know this person is going to show up and complain of symptoms, what's the value of that? Well, the value of that is when they first start complaining of symptoms, you know what those symptoms are coming from, and you can initiate treatment earlier rather than later. In a perfect world, which I visit sometimes, but we don't live in, okay, I would take this patient and send this patient to an interventional pain management specialist, and I would block the lumbar sympathetic chain in that right-hand side before she ever had symptoms. And maybe, just maybe, she would never develop symptoms in that limb. I can't do it because I can't get insurance to cover it, but if I know what I'm dealing with, the first time that woman comes in and says, my leg's a little sore, I'm on it because I expected it and I know what to do with it. All right. This to me was one of the most interesting cases, and I made this my last case. The 17-year-old high school student had one symptom. He had pain in the rib cage on the right-hand side at the very bottom of his ribs, right above where the liver lies. And I couldn't create the pain. If he coughed, if he sneezed, if he laughed, it didn't make it worse. But when I palpated that spot, he jumped off the ground. Okay, the pain was so bad that he literally had trouble breathing. He couldn't take a deep breath. He had that shallow breath that you get when you're hyperventilating. Okay, and I could repeat it by touch, but I couldn't repeat it any other way. And to be honest with you, when I first met him, I thought he was trying to stay out of school. I was trying to stay out of work from his after work job. I thought he was just it was all in his head. So we did a CAT scan, that was negative. We did an MRI, that was negative. I sent him to an interventional pain management specialist to block the intercostal nerve, that was negative. We blocked his thoracic nerves, that was negative. We tried trigger point injections, that was negative. We scanned his liver, that was negative. His blood panel was negative. I had nothing. And to be honest with you, pain management guy had nothing. And I put him in front of a thermographic camera. Now this is from his front, and I don't take abdominal. These two spots are where he had the pain. And in comparison to the opposite side, there wasn't a big difference, 7/10 of a degree. And I expected to see this. This is his sternum. This is his breastbone. This is his back. And what I didn't expect to see was this. I did not expect to see this cooling in the upper. This is the front, and this is, if I turn them around, this is the back. I did not expect to see this. And so what we wound up doing was we wound up treating his really, I mean, truly atypical CRPS before we were able to get him some relief. Okay. Interestingly enough, up here, getting up in the upper chest toward the axilla, when you look up here, there started to be a difference up here, which I saw, and I wasn't really sure what to make out of this until I saw this, and then everything sort of came together for me. So I've used thermography in two venues. I've used it three. I've used it to confirm a diagnosis. I've used it as an exploratory tool for its predictive possibilities. And we use it in a lot of instances in medical legal work, because those of you who are looking at thermograms for the first time are able to see what I see, in the assumption you're not colorblind, because you can see the fact that the human body is and should be symmetrical. And if it's not symmetrical, that it's incumbent upon the clinician to determine why there is not symmetry. And despite everything else I've done, and when I'm in practice almost 48 years, despite all of that, okay, it's the best diagnostic tool. It's the only diagnostic tool, quite frankly, that I rely upon once I have ruled out concurrent disease. There's a statement on my website. I'm sorry, there's one more that I forgot. There's a statement on my website that says that I've never seen a patient with CRPS that did not have an abnormal thermogram. I've been called to task on that by lawyers, but it's the truth. I've never seen one. Here's my last case, and then I'll take any questions you have. A 36-year-old female, 9 years after a motor vehicle accident, had four-limb pain, negative MRIs, negative EMGs, no medical, but all four limbs bothered her. Here's her thermogram: left hand, right hand, green, blue. Fingers are different. And there's her legs. The migration of disease happens more often than not. I would say to you that in all probability, 75 or 80% of all patients have migratory disease. So you have a patient that has, in this case, what I found interesting, she has a cold right hand, okay, and a cold left leg. So this is me. My website is there. I will answer any questions that people send to me by email. People laugh at me because I still have an AOL account, but it's trustworthy, so it's there. The website has more information on it. There are YouTube videos. I don't get paid for YouTube videos, but I've done a number of lectures that we put on YouTube that discuss CRPS in greater detail. If I can leave you with one thought today, two. One is, if you're not sure if a patient has CRPS, utilize the thermographer in your area and get the pictures, because it's still the best diagnostic, if not the only diagnostic tool, to reiterate what I've said. More important than that, if you have a patient who comes into your office, or you know somebody that has a problem, and they're not getting the right diagnosis, and they're not getting the right treatment, and they just don't seem to be getting better, okay, consider that it may well be a CRPS condition, and insist that they see somebody who understands the disease, because you're not doing them any great favors by mistreating them, treating them a different way, doing this, that, and the next thing. It's incumbent upon you as a friend, a neighbor, a relative, a clinician, to get them in front of somebody who understands as soon as possible, because until you do that, they're not going to get the right place. And the longer it goes, the harder it is for those of us who treat this disease to undo the mess. For those of you who are listening, if you have any questions, I'm a bit hard of hearing. I may not answer them, but we'll do the best we can. Let me do this. If I'm not, I'm also, there we go. I'm also technologically impaired. So, if I don't get this right, I apologize. I do the best I can do. And by the way, if you want to blame somebody for the picture that was on the announcement that came out to you, Dr. Mustafa used an old picture and not a new picture. This is what I really actually look like.
Wow. Thank you so much. That was, I'm blown away. I'm thinking of people in my life who may have not been properly diagnosed. I'm thinking of people in our spheres and our networks who can use their thermography so much more and in such a better way now with the explanation you provided. I'm really excited. Thank you so much. I'm going to open it up to some questions. Dr. Mostovoy, did you want to start? And sorry, before we start, Dr. Getson, sorry, if you can just click on the stop share near the top of your screen. There's a red button that says stop share.
I got it.
Perfect, you got it. Okay.
Thank you.
First of all, thank you very much. That was really very, very educational and very insightful. I realized something during your presentation when you said that some people happen to be in pain because of the vibration of another car. That's exactly me. I'm not in pain. I'm just so annoyed by other people's nasty music. But I'm not sure if that qualifies as a diagnostic criteria. Maybe not physical, but definitely mental issues. I wanted to ask you something that got me thinking. Do you think it's kind of has anything connected to autoimmune system or autoinflammatory system?
There's no question that this is an autoimmune disease.
Mm-hmm.
I mean, as I said, I kind of consolidated things for time constraints. There's no question this is an autoimmune disease. I'll tell you two other things. It's a genetic disease. I've got like 25 families where more than one member has this disease. That's not an anecdote. Mm. It's a genetic disease. And on top of that, it's genetic for two reasons. One, you pass down through family. Two, the RSD statistics are that it's 60% female and 40% male. That's baloney. It's about 85-15. There's a reason women have this disease. Okay. Now, you ask a woman, they tell you it's because a man can't stand the pain. It's a whole different story. But I say 85% women. Interestingly enough, if you take a woman who has CRPS and she gets pregnant, when she gets to the last trimester of her pregnancy, almost always that pain goes away. And it comes back after she delivers the child. So I've had women breastfeed the baby for 4 or 5 years just to keep the pain at bay. And we've never been able to figure out why, mostly because when you try and do these research studies, they started, well, let's put $1 million aside to do this, and we'll work up from there. Where do you get that money? That money comes from pharmaceutical companies and from this. Nobody's going to put up that kind of money. So I just compile statistics. Is it autoimmune? For sure. Is it an inflammatory condition? Absolutely. And there are 4 different pains of this disease. There's the inflammatory pain. There's the muscular pain. There's the deep pain, which is pure neurologic. Mm-hmm. And then there's sort of a combination of all of them. And so people who eat an opioid because of the pain, I said, before you take that medicine, okay, is it muscle pain? If so, deal with it as a muscle problem. Is it inflammatory? Deal with it as an inflammatory problem. Don't just eat your oxycodone and think everything's going to go away, because it doesn't work that way.
I remember watching one of your lectures years ago where you mentioned that most people actually focus on heat. And when it comes to CRPS, you're mostly focusing on cold. Is that correct?
Yes.
What's the connection there? Can you explain?
Yeah, it's the vasoconstriction of the vessel from the central disease. Everything starts out hot, and as the disease progresses, you get vasoconstriction of the the vessels, so you're seeing cold. If you talk to a CRPS patient, almost always they will tell you, my hand feels like it's ice cold, and yet when you actually feel the hand, it's not.
Uh-huh.
Occasionally, like I say, 20% you get the opposite, but your classic CRPS patient will tell you that things feel cold when in fact they really, in the real world, they're not, but that's their perception. So I'm looking at cold, recognizing that, again, in 20% it may be hot.
I guess you wouldn't, if someone has not had a baseline thermography, you wouldn't know where they are in terms of the progression of that disease.
Well, you know, you and I both, as thermographers, we have a sheet in front of us telling them where somebody hurts. So when I'm looking at that, and if the left arm hurts and the left arm's cold, you know, 1 and 1 is 2. If the left hand, if the diagnosis, if the diagram says left hand, but the thermogram is right hand, then my question is, well, how long have you had this? My first question, because there's that sort of 6-month arbitrary window, or are they the 20% of people? The only time you really get into trouble thermographically is if somebody has symptoms in both hands. And then the value of thermography is to pretty much tell you where it started, because one hand's still going to be worse than the other. They're not going to be symmetric. You're going to have a lack of symmetry. And in a case like that, it may not be the left hand is colder than the right. It may be that the gradient from the upper arm to the lower arm is in excess of what we expect. You know, the farther away you get from the heart, the colder the hand is going to get. But if the difference between the elbow and the wrist is 2.5 centigrade degrees, well, okay, I mean, that's not physiologically possible in a human being. So it sends up those red flags for us as interpreting thermography.
Looking at some kind of general description of CRPS, it's usually stated that it's incurable. Now, based on your experience, you know, I have a feeling that in many cases it is curable, whatever cure it is.
No, it's not curable. Okay, this is an incurable disease, and when the person sitting in front of me begins to cry because they now have an incurable disease, I tell them we're full of incurable diseases. Diabetes is an incurable disease, okay? But you can control it. You know, diet, lifestyle changes, medication, whatever it takes. You can actually look like a non-diabetic numerically. You can act like a non-diabetic. You can function like a non-diabetic, but you still have diabetes. So it's really not different than any other chronic disease. The goal is to get it under control, not to cure it, because I'm not going to.
And from your experience, you know, what's the percentage of the people that may have a normal life?
I have 2 answers for you, okay? The RSD Association of America says that the average patient goes to 4.3 doctors before somebody makes an accurate diagnosis. So I always told people that I was the 0.3. So if I get somebody and they in fact have been to 4 or 5 doctors and had these procedures, that surgery, I am not going to get them cured. I am not going to get them into remission. In all likelihood, I can make them better, but I probably will not get them into remission. If I see somebody 6 weeks, 6 months after an incident and they haven't been messed up by the medical community, I have a much greater chance of getting them back into a remission and giving them a normal lifestyle. And I tell them, look, okay, there's things you're not going to do. You're not going to go water skiing. You're not going to go hang gliding. Okay? You shouldn't get on a motor scooter. You know, but most of these things that you can live a long and happy life without.
Right. Okay.
You know, I'll tell you one very quick story, and I'll abbreviate it. I had a woman who came in to see me who wound up with a tear in her wrist from a thing, and the doctor operated on her hand, and she wound up with a purple cold hand, and he missed the diagnosis. And 2 years and 6 more surgeries later, 7 surgeries, 6 of which she did not need. Okay, because the RSD was migrating from one place of the body to the other. She came in and said, what are you going to do to make me better? And I said, unless you have a time machine, nothing. Okay, because they had kept operating on things as the disease migrated from one part of the body there. They kept fixing things. So that she's one end of the, and yet I've had people come in, they got hurt a month or 2 or 3 months ago. You get those people back to almost complete remission, with proper treatment and luck, and you can get them functioning in a normal way. I would say that of my current basic, I probably have maybe 10% that are working, and probably another 15% who have a reasonably normal life. They're living alone. They're doing their food shopping. They're not shoveling snow, but they're having because you can do this. Once you get them to buy into the program, eating right and doing the right things. So I mean, it all depends upon that. And when I get insurance companies that argue with me and say, "Well, why are you giving them ketamine for the rest of their life?" I say, "Well, why are you paying for insulin in a diabetic for the rest of their life?" They're different. It's a different disease, a different drug, it's the same problem.
I'm fascinated and kind of not surprised by your connection with fibromyalgia. I find that in most cases that I have come across with so-called diagnosis of fibromyalgia, these people have been misdiagnosed. And so easy to misdiagnose for fibromyalgia because like any syndrome, anything with the syndrome, we all know, it's questionable whether it's the correct diagnosis or not. So you see that as a subset of fibromyalgia, or fibromyalgia is a subset of CRPS?
Fibromyalgia is a subject of CRPS,
right?
My opinion.
Right.
Yeah. You understand as well as I, and I'm sure many of the people listening, if you can't see it, maybe it's not really there. You don't see fibro, you don't see CRPS. You can see it, blood sugar of 250, or an X-ray of a fracture. What does somebody with CRPS look like? It looks like you and me. Okay. What does a diabetic look like? It looks like you and me. And that's the problem with a lot of chronic disease. You can't see it. And except for the thermogram, you can't diagnose it by test. So it must not be there. All right. I just think that when you look at that slide there's 2 slides about fibro, the description by the fibro people of fibro, not by me.
Mm-hmm.
The fibro is diagnosed by the National Fibromyalgia website. The way CRPS is diagnosed by the National CRPS website, they're virtually identical. There's a reason for that.
Yeah, wandering pains, and nobody knows what to do with it.
Nobody knows what to do with them, but what difference? I mean, call it Fred. I don't care what you call it. Shakespeare said, "A rose by any other name would smell as sweet." It's the truth. Actually, George Carlin was better because he said, "How can we drive on a parkway and park in a driveway?" Mm-hmm. But the point is, it doesn't matter what you call it. Okay, it's just what you do with it once you realize what it is.
Right. Okay, that was great, Callie.
A couple of questions. So does the CRPS have to be caused by some kind of like an accident or something kind of abrupt, or is there any kind of a slow onset potential?
So the answer is yes to the latter part. I would probably tell you that of all the people that I've seen, about 1%, have an insidious onset. You just can't identify why it happened. Most times, if you really spend a lot of time and take a history, you can figure it out. But every so often, one comes in and there's just no reason. It just is.
Mm-hmm. Got it. Okay, another question just came in, and then I have another one. So is there any specific pattern you can see when analyzing BTT with thermography? I'm not sure what BTT is. So the person who put this question, if you can just add another message here and just tell me what you mean by BTT. So is there a specific pattern? Oh, brain tunnel temperature. So I'll finish the question. So it says, is there any specific pattern you can see when analyzing BTT with thermography in this particular disease as per your experience? And then there's another question. Are there any emerging studies on the efficacy of the integrative approaches specifically regarding healthy eating? So one is the BTT and then the healthy eating and integrative.
Well, in terms of thermography, I'm not doing a thermogram blindly. I'm doing a thermogram on somebody that has the clinical presentation to suggest that they have CRPS. So I'm already kind of geared to say, all right, you do or you don't. I'm looking for a lack of symmetry, plain and simple. It's what we look for in thermography in general. There are criteria that I use, that have to do with centigrade degrees. I'm looking for an asymmetry that's more than 7/10 of a degree before it sparks an interest in my mind, and more than 1 degree before I'm willing to call it abnormal. And usually it's disseminated, meaning it's the hand or finger. It's not, as I said to Dr. Musselwhite earlier, it's not from one portion of the arm to the other, although that happens on occasion. So there's no specific pattern or number that I'm looking for. I'm looking globally to see if there's a lack of symmetry. And as I said earlier, somebody has a problem with their hand, I'm still doing the whole body. I missed the second part of the question about emerging.
Yes. So are there any studies on the efficacy of the integrative approaches specifically regarding eating healthy? So these approaches to healing and therapeutics, are there any emerging studies on that?
Not that I've seen. Integrative approach is I've learned, I'm a conventionally trained doctor, okay, who married a woman who said, you're looking at this the wrong way. So I started looking at it from the other side of the coin. And that's why we talk about gluten sensitivity and Reiki and all those things. I think that there's probably, you can drop CRPS into the integrative approach for all chronic disease, and not separate it as an entity. An integrative approach to diabetes would be the same. An integrative approach to hypertension would be the same. A matter of getting the patient on board and dealing with diet and lifestyle and wrapping your mind around a whole different series of events, and not watching TV where they give you a commercial and you run to your doctor and say, take this drug. We as conventional physicians have been doing it wrong forever. I'm not embarrassed by that. Some people see the light sooner than other, but it's always been wrong. Writing a prescription for somebody to treat a symptom has never been the right way to do anything. And so you need to sit down and first identify the problem, which is where we talk about thermography, and then once identifying the problem, identify everybody's role in that. The patient, the patient's caregiver, the patient's family, the patient's nutritionist, the patient's primary care doctor, because everybody has a role, and getting everybody on the same place, with somebody like myself being the quarterback, recognizing there's 10 people around me that have to do their job as well, or otherwise it's not going to be successful.
Well, that makes a lot of sense. And then the last, or one more question. So you're welcome. So we got a big thank you very much for your answer, your experience, your time. Very interesting. And you're coming in from Spain. So wonderful. Thank you so much. And then another question is, on one of the slides, you mentioned a few different connections to things, and one of them was dental. I'm not sure, was that the CRPS can affect dental, or dental can affect CRPS, or can you explain a little bit more about that?
Okay, so again, I have two answers. Number one, when I do a full body study, I do not do the mouth, okay? And we probably should in some instances. You can do dental thermography and identify areas of heat that are problem areas, and we do that separate of CRPS. And sometimes if a patient has CRPS and has a dental area, we're looking for infection or a problem. But the CRPS affects the teeth. I mean, I had a woman came in and it's kind of one of those, I brush my teeth 4 times a day. I go to the dentist every 90 days. I mean, one of those fastidious care for my teeth. And I saw her one time at a 3-month interval, and her teeth went from the poster child for dental health to gray. I mean, literally they were gray. Every tooth in her mouth was gray. And I looked at her and I went like, what happened? She said, I don't know. Okay. My teeth are chipping. One tooth fell out and they all turned gray. And within 3 months, all the teeth in her mouth were pulled. We pulled every tooth out of her mouth because they were literally falling out of her mouth because the nerve roots were deteriorating from the CRPS, and we wound up taking every tooth out of her mouth. 40-some years old. I had them as early as 20, literally have every tooth in their mouth extracted, and there's no rhyme or reason for it. I can't tell you that this is somebody to look for or not look for, whatever. It's just a facet of what happens. And when it does, if they're, you get a 20-year-old who has no teeth, it's sad. I mean, you get a 40-year-old have no teeth, it's sad. But they literally just rot out of their mouths. And there's not a darn thing you can do other than try to do your best to get the CRPS under control. Because if you can get that under some kind of control, maybe, it affects it in a positive way, where some of the symptoms, some of the signs of CRPS are getting better because you've made the central core problem better. Not just the hand pain getting better, but now the nutrition and nourishment to the teeth is getting better. And as I said in that slide, it has to do with the drugs. It has to do with mouth breathing. It has to do with the foods that we eat. I mean, every part of this disease is multifaceted. It's just multifaceted.
Wow. Thank you. That's all for the questions that were submitted. So thank you for answering all of that. And thank you to those of you who submitted questions. And in so much gratitude for this informative, holistic, and educational presentation, which has helped me understand this autoimmune disease as a massage therapist. You're welcome. And thank you so much for being here. To everybody, please, we are going to send out a copy of this recording once it's ready. So look out for that in the next few days. Please share it with people in your life, friends, family, neighbors, other practitioners. The more people can have this amazing information, the more people we can help, and the sooner. Dr.
And I appreciate the opportunity of you both allowing me to reach out to people that I couldn't otherwise have contacted. And hopefully some people will get the information out of this that will allow them to help people. There used to be an old commercial about I told two friends who told two friends who told two friends, and that's what this is all about.
Yeah.
Thank you, Dr. Katzen. Much appreciated.
Thank you.
Bye-bye, everybody. See you next time.